Mike, do you want to do any housekeeping things, or should I just introduce myself and then let William? How do you want to do it?
I'll introduce you. I got the little brief bio here, but
Okay,
welcome back,
sounds good.
everybody, to our third session of the day. It's going to run from 2:15 to 3:15. We have William Marshall and Patrick Hindman talking a little bit about health disparities, the connection between alcohol and health disparities. So we appreciate their help. William is the Epidemiologist of Health Disparities at the Michigan Department of Health and Human Services. He specializes in the study of health inequity and marginalized communities and disparate conditions of racial ethnic health in the state of Michigan. Patrick Hindman is the current alcohol epidemiologist for the state of Michigan. He has been in this position for nearly 4 years. Prior to his work, Patrick spent 2 years as an epidemiologist for the state of Arizona, specializing in sexually transmitted infections, and 10 years as a restaurant manager. Patrick earned a Bachelor of Science and nursing degree from Western Michigan University in 2009 and a Master of Public Health degree from Michigan State University in 2014. So without further ado, welcome Patrick and William. Thank you for helping us out, and we are looking forward to the presentation.
Awesome. Thanks for the quick intro. As Mike said, I'm the current alcohol epidemiologist with the Department of Health. Been here for about 4.5 years. Been working with Mike pretty much the entire time, from helping with various projects that he's working on, with all you guys, to working on some stuff, between him and I and other alcohol related endeavors. William, do you want to say anything quickly about, your job or anything? I know Mike gave a little preview of what you're doing, but.
Yeah, sure thing. And also, thank you very much for the introduction there, Mike. And, as Mike and Patrick have both said, my name is William Marshall. I am the current Epidemiologist of Health Disparities for the Michigan Department of Health and Human Services. And while I'm relatively new to my field, the general focus of my field is really trying to evaluate and look at many of the various sociological aspects of Michigan that influence the health of the Michigan citizenry. So not just the Michigan population as a whole, but all our various racial, ethnic, and various groups as broken up by different sociological factors across the state. And what I'm doing in my role is really looking at how does Michigan's sociological environment really affect its health, and how that can lead to disparities in health when we see disparities in that sociological environment. So I'll go ahead and leave it to Patrick here, but that's kind of a summation of what the health disparities epidemiologist does.
Great, thanks. So as Mike said, today we're going to talk a little bit about how alcohol and health disparities are connected, and we'll go through our slides. And one thing I like to say from the start, in the beginning when I do presentations, and William's on board with this, is if you have questions or comments, we would prefer that you go ahead and ask them right away. I know that's not the norm, but I feel like in the past with my presentations, we've gotten really great conversation and good participation when folks are able to ask questions when they have them, as opposed to waiting to the end and then maybe forgetting or just deciding they don't want to ask. Ideally, this would be as interactive as we can make it and as we want. So please feel free to raise your hand. We did already test that out. That works well. We saw Emily raise her hand earlier and we were able to let her talk. So feel free to raise your hand or type a question in the Q&A as they come up, and we will address them as we talk. I like to answer questions on specific slides when they come up. So please feel free to interrupt us and ask us questions as we move along. Like I said, I think it does make for a little bit more interaction, and it keeps your questions relevant to the slide that it probably is on, instead of having to go back and find it at the end. So please don't hesitate. Don't be scared. Please interrupt if you have questions. That's what we're looking forward to. So let's go ahead and get started here. I think I've got to click on this. There we go. So I want to start out with just some basic definitions of drinking. Excessive drinking includes binge drinking, heavy drinking, and any drinking by pregnant women or people younger than the age of 21. Binge drinking, which is the most common form of excessive drinking, is 4 or more drinks on an occasion for women and 5 or more drinks on an occasion for men. And that's generally within a couple hours. There isn't an official time, but it's about 2 hours or so. Heavy drinking would be 8 or more drinks per week for women and 15 or more drinks per week for men. And then I'm gonna let William take over from here, and I'll chime back in when he is done with his slides. Go ahead, William. Let me know when you'd like me to go to the next slide.
Okay, can do. And so, as Patrick said earlier on, if you have any questions, feel free to ask them now. We have the Q&A tab here in Skype to go ahead and put questions up. And we also have some individuals keeping an eye on that to let us know when we get questions. So please feel free to interrupt and ask the question whenever you want to. So going into this presentation, this is a presentation some of the interplays between what we call the social determinants of health and our various alcohol epidemiology we see here in the state of Michigan. But that kind of begs the question, what are these social determinants of health? So the social determinants of health as a concept is something that has kind of been bouncing around since the early 2000s, but has been most well defined by a recent government initiative by the US government and the Center for Disease Control called the Healthy People 2020 Plan, which was made back in 2010 to sort of lay out a framework for being able to look at the American population in novel ways to get a better understanding and a handle on American health. So the concept that they help to define here is what we call the social determinants of health, which at its most basic level is a combination and a culmination of all the conditions in our social environment, our physical environment, our economic environment, and all of the various aspects at all the different levels of that social, physical, and economic environment that stack up together to really influence our health. So in a way, the social determinants of health is a kind of environmental look at our health and how the environment affects it. But it basically looks at not just the physical environment, but the sociological environment too. So Patrick, can you go to the next slide for me? Okay, so what do we mean here by the social and physical environment? So when we're talking about the social determinants of health, we really look at the effects of the social environment and the physical environment. Now, our social environment can really be an aggregate of everything from our individual cultural norms, beliefs, and systems to the different beliefs and relationships that we have with our family and interpersonal relationships, but can even go as high as the actual societal environments, such as our governments or our larger country as a whole. But at each of these levels, we are looking at everything that kind of forms the sociological environment you live in. So when we talk about our family and interpersonal relationships, we are not just looking at, say, how many people you have in a family, but we're also talking about what's the history of your family. For example, here in America, we can say, has your family been one that has been wealthy for multiple generations and has accumulated wealth throughout those generations? Or are you, say, for example, from a poorer family who has not accumulated wealth through those generations? Where does your family live? What are the beliefs that your family has that can help to influence how your health can develop? Not just even religious beliefs, but even interpersonal beliefs. But when we talk about that interpersonal level, we can extrapolate that to the larger level too, such as What is the larger local culture or even culture at a state level? What is the culture at the national level? And what are the actual practices of this culture, or even some of the more set in stone foundations, such as our government? For example, how does your government treat its population and its citizenry in terms of health? The other aspect that we look at besides the sociological is the physical environment. So here we are talking about not just the built environment of, say, for example, urban or rural areas that we live in, and everything from our homes, houses, the physical buildings we work in daily. We are also talking about the natural environment too, our local environments. For example, do we live in a heavily abundant area with a lot of nature around it, such as suburban areas, which tend to be fairly green spaces, or rural areas in which you have large amounts of forest around you? Or are you living in urban spaces, which can have a dearth of a natural environment? Are you living near river systems? Are you living in the colder, more temperate regions of the north of the United States or the world? Or are you living in more tropical areas that can be affected by natural disasters? When we talk about the physical environment, it is a combination and an interplay between our built and our natural. So going on to the next slide to elaborate more into some of the impacts that our environment can have on us, we are going to look at the social environment and how that can impact our health. So when we think about the social environment and how it can really shape a person's health, we look at not just the individual behaviors, for example, the explicit or implicit biases that people may have that can influence different decisions in our life, such as hiring processes, school-to-school interactions, or just even interpersonal interactions. We are also looking at some of the things that are commonly more tangible that we tend to think about that influence health, such as our societal structure and the social resources that we have in that societal structure. So this includes things like our educational and our job opportunities. Do we live in an area that has decent access to education, that has well-funded school systems? Or, do we live in an area without that? Do we live in an urban area with a bevy of job opportunities, or do we live in an urban area that does not have that? Those are aspects of our social environment, but everything else can also be an aspect of that too, such as our incomes and the wealth distribution of our local area. Things such as our health insurance and our health care. For example, are we living in a system with privatized health care in which we are getting health through our job, or are we living in a system with more public options? Do we have health care and health insurance? Do we not? All of these play into the social environment, and as such, we can see these social resources, but we can also pull back and look at the actual government and larger social systems that influence that. For example, we can go ahead and look at the history of the United States in terms of our own legal practices for how they shape the social environment throughout history. For example, we exist in a country that did have slavery, but has now moved to an area of post-civil rights. How does the legal system change in terms of treating people throughout that time period? Do we see remnants existing throughout that time period that can disproportionately affect people in terms of their social standing, which can then disproportionately affect their health? But going on, we have the other side, which is the physical environment on the next slide. And here we can see that the physical environment can also impact our health in much different ways and can provide things such as health harms or health improvements based on what our physical environment looks like. For example, our physical environment can be everything from our home and how our houses are built and how wealth can influence the building of that house. For example, we have a lead crisis here in Michigan, which can be greatly related to the structure of your house. For example, does your house still have lead paint in it? Do you have the ability to afford to remove that lead paint? Do you have the ability to actually renovate your house in meaningful ways to go ahead and make it be less toxic to your environment? Those can be aspects of the built environment at the small scale, but they can extend upwards to the larger scale. For example, in the Flint wire crisis, we not only have an issue of older houses with lead pipes, but we also have the larger governmental shift in a simple change in our water provider, in which shifting over to another water provider caused greater exposure to the entire population to lead and other heavy metals that were extremely toxic. And those are aspects of the built environment that can easily be shifted to provide what used to be a health benefit of a relatively clean water supply to a health harm, such as an unclean supply. And every aspect of our physical environment can impact us in these ways, not just the built environment of what we physically make, but the natural environment too. For example, when we look at the health of individuals without houses, where you live can greatly impact, how your health can exist at different times of the year. Here in Michigan, we have extreme cold environments, and we oftentimes see a rise in the deaths due to environmental exposures in the homeless population once it literally gets too cold to live outside. But on the flip side, when we move to the south in the more tropical areas, we can see individuals being greatly impacted by natural disasters such as hurricanes. For example, when we look at New Orleans, we see that you have your less wealthy populations with less stable built environments not being able to recover as well when a hurricane blows through and breaks down their houses. And you see an interplay between the social and the physical environment here. The social environment of not good wealth distribution affecting the houses that we build, and then the natural environment providing a hurricane, and then the inability to recover, as well as your richer counterparts, which can then lead to pervasive health issues down the road. But, these two environments interplay in many ways, but we can come up with some more defined ways of talking about them that we call the social determinants of health. On the next slide here. So, going and pulling back everything we talked about from the physical and social environment, we can go ahead and take those two and come up with some more simpler ways of thinking of those two environments in more concrete terms that are more easy to define and more easy to link to actual health outcomes, which we call the social determinants of health. So we break it up into 5 general areas that are a sort of combination of the physical and social environment that are very easily related to health outcomes. These are economic stability, which is everything from what your employment is to what type of welfare and social protections you get in and outside of that employment. Your education as the second area, your social and community context, your health and healthcare, and your neighborhood and built environment. Under each of these categories here, we have many different things that, throughout extensive study in epidemiology and sociological studies have been shown to have very direct impacts on our health outcomes. But the thing is that with these social determinants of health, every single person has a combination of these. No one really exists without their social or physical environment, and these social determinants of health affect everyone. But their distribution and how much you have in one of these 5 areas can differ. and that difference can lead to a disparity in your health outcomes. So going to the next slide, when we talk about a health disparity, what we are really talking about is a difference in the health of a population that can be more so linked to a difference in the combination of social determinants of health, in the combination of their physical and social environments that could lead to differences in social and economic and even cultural differences that basically come to influence their health, that can make a disparity or a difference in the health outcomes between two populations or even smaller groups of individuals. So when we think of these health disparities, some prime examples that I've brought up throughout this whole long winding conversation here are, for example, the issues of the Flint water crisis. When we look at the African American population of Flint, in which Flint has a very large African American population, we see an interplay between race and socioeconomic status. Individuals in the city of Flint, of a lower socioeconomic status, which is a large population of the city, do not have the means and resources to be able to adequately protect themselves by providing necessary renovations to their houses to have a nicer built environment to live in. So we see one of the social determinants of health, their actual economic status coming into play there. However, individuals with more wealth, who tend to be the mainly white residents of the city of Flint, do have more wealth and are able to make better renovations or are able to afford different means to kind of get around that larger water crisis that exists there. But that difference in the social determinant of health leads to the health disparity of the difference in lead exposure levels between the two groups, which can lead to a bevy of different health outcomes, such as birth defects and many other things. When we see health disparities like that, our main prescription to treating them isn't to simply address the health outcomes themselves, the actual lead exposure, but is to also try to address the underlying issues that led to that disparity in health outcomes, which is why not only in the case of Flint do we see the handing out of water filtration devices to remove lead from the water supply to help treat those negative health outcomes of lead exposure, we also see state level action to then try to pass legislation to further protect the population of Flint for many years to come, to basically address the issues of lead exposure in the first place, which really are a social issue at its underlying core. So, those are health disparities and the social determinants of health. So this seems very tangential to alcohol epidemiology, but the truth of the matter is that the social determinants of health play a very key role in some of the differences that we can see here in alcohol usage and some of the negative health impacts to alcohol, which my good friend Pat here will be able to elaborate more on. And also, any questions or anything like that, feel free to ask.
Yeah, before I move on to additional slides that I have, does anyone want to chime in on what William has said, ask any questions, any comments, anything like that? I see we've got a raised hand here. I'm going to unmute Jessica. Let me.
Hello,
Jessica,
William.
I think, there you go.
Okay.
Hi, I had a question. I was wondering, because I do live here in Flint, and I can really relate to the social determinants of health, but there's one thing about it. You grow up in a deprived environment. You might have state assistance for medical, you have state assistance for food. You grow up in the educational system, which is not that good, but by some chance you happen to make it to college. and then you change your neighborhood, and then you have health insurance and you have income. Is there any particular reason why, if you make those big changes to your life, does it seem like I still had a baby that was low weight, birth weight? And so although the environments and every single thing changed, it seems like it did not change me, maybe genetically, if that makes sense.
Yes.
So how long, or do you believe, or how far removed from poverty do you think a person or a generation would have to be before you actually start seeing a genetic change?
I would have to say, and thank you very much for sharing your story. I would have to say that it would have to be a very long removal because, it's a sort of old adage, but, our history never really escapes us in any way. So, while an individual can, of course, grow up in a very poor environment and face all the health impacts from that, but then completely change and shift to a much richer and a much more supportive environment for them, it's still very hard to go ahead and escape the influences on your health from being raised in such an environment. Lead exposure is something that affects us all the way from birth throughout the entirety of our life, and can even affect the development of our children based on our own lead exposure. So, when it really comes to it, we are talking about really a change that happens not just on a individual lifespan, but on a multi-generational lifespan, or well, on a multi-generational time scale, to be more correct there. So I would say, when talking about the social determinants of health, they are the type of large macro scale impacts that affect individuals both in their own life, but can also affect all subsequent generations of an individual for years and years and years and years. A good analogy to this is sort of the multi-generational impacts of segregation on our population throughout the past 100 years. We see that in the Jim Crow era, segregation laws really did parse apart African Americans from the rest of America in many different aspects, not just in where you can live, but in what you can do, who you can see, how you can behave. Everything like that greatly segregates our entire population. The thing is, though, Jim Crow era laws still have lingering impacts even after the civil rights movement, which only occurred 50 years beforehand. So while redlining, something that kind of comes out of the Jim Crow era, separates out our urban environments where we see African Americans concentrated in specific sections of many urban regions across the entire United States of the era due to redlining from the Jim Crow era. Even though the civil rights movement happens in the 60s, we can still see many of those large urban areas that were redlined almost 100 years ago, still having these same demographic layouts 100 years later. And even though the civil rights movement happened 50 years ago, it could take centuries to have those dense urban clusters that were set up via redlining to actually see legitimate movements in those populations, and then to see legitimate changes in their health statuses from the impacts of being segregated to some of the worst areas in a city environment, and having to face the generational exposures to the factors that come from those poorer urban environments. Mm-hmm. So it's a long time to see impacts and changes, and they will persist for a very long time, even after you make drastic change?
Good question. Good answer. Anybody else? All right. I think we'll take that as a no and we'll move on. William will still be here at the end, so if something comes up along the way, we'll be able to ask more questions of him later as well. So let's move on. I'm going to talk a little bit about alcohol and health in just sort of basic terms. Roughly 93,000 people die from alcohol-related causes annually, making it the third leading cause of preventable death in the US. And I'll mention that this number 93,000 is about only 2 or 3 weeks old. The CDC just released a new study on this, so you can find that. I think I have the reference there for this, and if not, I can send out the study. It's a new study, just came out. They have updated it from 88,000 to 93,000. So that is new. I see a hand raised. Let's see what we have here. No hand raised. I thought I saw something saying there was a hand raised. Perhaps I'm wrong. Maybe one of the other folks can check it. Alcohol is associated with both short and long-term health issues, such as motor vehicle crashes, falls and drownings, heart disease, stroke, and high blood pressure. That's just to name a few. There are several more. Alcohol is a risk factor for numerous cancers, including liver, breast, mouth, throat, esophagus, and colon cancer. Alcohol is a risk factor. Alcohol use is one of the most common risk factors for harm among adults in the US. 53.5% of adults drink alcohol, so more than half of our population. 16.2% of adults report binge drinking, which is what I said before, four drinks for women, 5 drinks for men in a row. 6.5% of US adults report heavy drinking, which again is 8 drinks in a week for women and 15 or more for men in a week. Drinking among young people is also common. 29.2% of US youth reported they currently drink alcohol, and 13.7% reported that they currently binge drink. I'm gonna show some slides from here on out that sort of shows the trends going on in our state. So this is Michigan data we're looking at, and this is binge drinking specifically from 2011 to 2018. As you can see, we are above the national average, which I'll go back to for your reference, 16.2% there. This is from the BRFS. We are above 18%. I think it's about 18.2 or 1%, something right around there. And it's been very steady since 2011. There's a slight decline, but not very much. We're talking 1.5 points maybe difference. So, you know, binge drinking is a steady common thing in our state, and even more so than nationally. This is binge drinking prevalence by gender in Michigan, again, 2011 to 2018. Again, very steady lines here. Men report binge drinking more than women, but again, like I said, very steady lines here, very little change. It's a common thing, and it's not changing much among our adult population. This is binge drinking by age. As you can see, without too much surprise, our 18 to 24 and 25 to 34 are among the top in binge drinking. And then we've got 35 to 44 and 45 to 54 following. So, you know, as one would probably guess, younger people generally binge drink more, and as people age, they tend to binge drink a little less and a little less. But I think it's still important to note that, you know, 55 to 64-year-olds are still binge drinking, you know, around 14%, which is a fairly high number for, you know, an older age group of folks. This is binge drinking prevalence by race, ethnicity. You'll see some sort of random dots out there. That's because we didn't have data that was able to be plotted on these graphs. So for example, the Asian non-Hispanic data, we don't always get enough respondents in our BRFS to be able to report that data. So you can see there's a lot of missing data for a few of our races. And like I said, that's a reporting issue with BRFS, excuse me. BRFS is a telephone survey, so we may not get to that many. I see a question from Kathy. I'm going to unmute you, Kathy. I think it might just take a second here.
Can you hear me?
Yep, I can hear you, Kathy. What's up?
Okay. When you see the trends uptick sharply, is there any other type of events going on during those times that can be pinpointed?
So if we're looking at the graph right now, among race ethnicity, we could look at the Hispanics from 2013 to 2014. There's a significant jump there. I'm assuming that's kind of what you're referring to, those jumps.
Yes. Yes.
Just thinking back in 2014, I'm trying to think if there was some sort of natural disaster or something. I can't remember off the top of my head, but obviously I think probably most of us, considering we're all in the alcohol and substance abuse prevention world, we've been hearing about how natural disasters and things such as the COVID-19 pandemic will cause an increase in drinking generally, and we've seen that. There's been numerous presentations out there that have talked about the increases that we're seeing in drinking and whatnot among this pandemic. So I'm trying to remember. I can't off the top of my head remember if there was some sort of event in 2014 or between 2013 and 2014 that would cause an increase there, but that's only among one race as well, so that's hard to say. I can try to go back again and see if that's I don't see any big jumps from 2013 to 14 there necessarily. But I think to answer your question, Kathy, yes, there can be events, world events, cultural events and things of that nature that can cause folks to drink more. I know we're seeing it right now during COVID-19. So, to answer your question, the answer is yes. I don't know exactly what it would be specifically for, let's say, that year. Does that answer your question well enough, I hope?
Yeah, thank you.
Yeah.
Sure.
And to chime in there,
yes, please
one
do.
thing. One thing that can also greatly affect the data here and jumps in it is the source of the data. So this is all behavioral risk factor survey data, which is a study I tend to work on a lot. And from the structure of it, the way it's done is in a kind of telephone calling random sampling method. So we basically have a quota of individuals we want to randomly call from the state, and we will essentially call them all out to randomly sample and do interviews to get the data that forms this information you're currently seeing now. One of the issues with that is that you can get a lot of error in that data, especially when it comes to smaller populations in the state, just because it's harder to sort of throw a dart at the board and be able to land a interview with individuals who tend to belong to a fairly small ethnic group in the state of Michigan, of which Hispanic Americans are a very small ethnic group in the state. So the random sampling method for the BRFS here doesn't really do too well with those smaller ethnic populations, which is why, as you can see here in the Asian non-Hispanic group, that's why you don't have so many data points for it, because Asian Americans are even smaller than Hispanic Americans and are even harder to sample with the method for the survey. So, these jumps may not be entirely representative of what's going on, just because of how hard it is to get to these populations, which in a way is also kind of a factor due to the social determinants of health.
Yeah. That's a good point. We can't always reach the same amount of those folks when there aren't that many, and like William said, social determinants of health probably play a role in that, with folks being able to have a phone, for example, to answer if they're being called. That's obviously something that they would need to have to participate in the survey. So thank you for chiming in. Let's look at binge drinking prevalence among adults by income level. As you can see, the highest income level tends to binge drink the most, followed by the second highest, but you can see again some jumps and dips and things. And as we were just talking about, it all depends on our random sample and our survey. We do the best we can to get as many folks as we can from all various backgrounds and everything, but there's going to be some weird jumps from time to time. And I think ultimately, if we're just looking at this from sort of a bird's eye view, you can see there's a lot of binge drinking going on, no matter how much money you're making. Even, the less than 15K comes in at over 15%. That's almost the national average. So, that's a lot of binge drinking among a group that makes less than $15,000 a year. So, that's I think, sort of an eye-opening way to sort of look at this data. Now we'll talk a little bit about trends among youth. Again, this is from the YRBS, or the Youth Risk Behavior Factor or Behavior Surveillance System. Again, this is, keep in mind sort of what we said about the BRFS with the data. We try to sample as many kids and things as we can. I think it's among 9th and 11th graders, or 10th and 12th. I know it's 2 different grades. But again, we don't always get the best samples. I think what we can take from this slide ultimately is that drinking has gone down among our youth in our state. And I believe it's very similar nationally. It is on the downward trend. That's not to say that our youth aren't still drinking. Obviously they are. That, currently drinking number is still above 25%. So that's quite a few. And, there are other things obviously that our youth are getting involved in. We've got legalized marijuana now, and I know the vaping issue has been a big thing the last several years, and I think there were several presentations in the last few coalitions that talked about vaping and things that folks were doing to help combat that. So even if our drinking numbers are going down, which are super great, our youth are still drinking quite a bit, and there are other things that they're doing. And one other thing I'd like to point out about this slide is the significant jump we saw among females. There's probably some weird data, I don't want to say glitch, but something with 2015 to 2017 for that huge jump, and then to fall right back down closer to what it was before. But, more females are drinking than males lately, which is an interesting fact, and something that I think a lot of people are really trying to dive into and figure out, what's going on. It's been up and down over the years, but they're drinking more, and I know it's something people would really like to know why. This is youth drinking by current race ethnicity. This is 97 to 2019. Again, some missing data points with small numbers. We don't have data for every year for some of the groups that, we don't have a lot in our state. But still going down, which is great. We like to see the downward trends. I think it's still, like I said before, important to remember, drinking among youth is considered excessive drinking in general. So any drinking here is excessive for our kids that are, 14, 16, 18 years old. Our white population and Hispanic population are the highest at 27, 28%. And then with the data that we have, our Black population comes in at about 13%, I believe. So quite a bit less than our Hispanic and whites. And this is binge drinking by our youth, whereas before this was just current drinking, so any drinking at all. And this would be binge drinking. So binge drinking is less than current drinking usually is. Again, we've got females above males, sort of that, what's going on here? Why are females binge drinking all of a sudden more than males in the last several reporting periods? Again, something we're trying to figure out. I think everybody, who's seen this across our state is wondering, what's the deal here? How can we target these groups better? What can we do here to try to bring that number down even more? But again, we're still got a decent number here for binge drinking among our youth, which is something I think, we are all obviously working on. I have a question here from the Q&A. This is from Jessica. That is very odd since liquor and party stores heavily populate Afro-American communities. And yeah, I was going to touch base on that a little bit in the next few slides, talking a little bit about outlet density. So I will touch base on that a little and hopefully answer that comment a little bit in the next several slides. And this is binge drinking prevalence among Michigan youth by race ethnicity. Again, some missing data points, like I said. We don't get great data for all of our various groups and races and things. But as you can see, whites and Hispanics, again, are among the top for binge drinking prevalence among youth. And then Black population, Black youth, fairly low, below 5%. So that's great. I don't know if William can speak to that as far as the health disparity issue comes or anything like that. But I think, you know, perhaps our Black youth are not drinking for reasons that I'm not aware of. I'm honestly would be scratching my head as to really know why. Maybe we're not getting great numbers from that population in the survey. And then I see here we have a hand raised. I will unmute Jessica. She would like to chime in. Jessica?
Yeah, I have a suspicion in working with the
Yes.
youth in the African American community when we talk about, you know, what are the drugs of choice. And from my experience, it has been marijuana and it has been smoking. And if you live in an environment where you're highly stimulated, highly on alert, you tend to go from things that will not make you more amped up, will not make you more angry. And so then that would be you choosing the marijuana. You don't want to drink and then get upset and cause a whole bunch of problems.
Sure.
And so it seems like that has been the drug of choice of trying to like maybe do downers.
Okay.
If that makes sense.
Sure, yeah. And that's you know, why I kind of posed the question myself out there. I was hoping somebody would have some hands-on experience and be able to chime in. So I really appreciate you chiming in with that comment. That I think that's helpful. And I think that probably definitely says something about the data that we're seeing here, that perhaps they're choosing other substances and going a different route when they're, you know, choosing to use, whether it's alcohol or marijuana or something else. So essentially, what does this all really mean? You know, we've got our alcohol numbers, our alcohol use numbers. You know, we've got quite a few people drinking in our state. I know we're among the highest in the U.S. as far as, you know, drinking and drinking deaths and other levels like binge drinking. We're above the national average. So what does this all really mean? You know, social and economic inequities that fuel health disparities could also drive alcohol exposure, consumption, and addiction disparities. Communities are exposed to alcohol products at different levels. Exposure to alcohol advertisements increases youth drinking. Researchers in New York found more alcohol advertising ads in subway stations located in high poverty areas. And I apologize that, you know, this isn't Michigan specific, but I think that this still tells a story about how communities can be exposed at different levels. In addition, subway stations with alcohol ads were located disproportionately in neighborhoods with greater poverty, lower educational attainment, and higher percentages of Black and Latinx residents. Some communities of color are at a higher risk for the worst outcomes of alcohol abuse. Alcohol played a role in nearly 12% of American Indian deaths, a rate double that of the rest of the American public. Compared to white people, Black, American Indian, Alaskan Native, and other people of color have less access to an alcohol treatment intervention. So that could be another big factor there. And I know William touched base on that as far as healthcare and things earlier in the presentation. Efforts to promote routine alcohol screening and intervention in primary care might not benefit all racial and ethnic groups equally. And then from there, we've got an increase in treatment disparities and exacerbate disparities in alcohol use. So, you know, I think ultimately what we're seeing here is, you know, folks are exposed at different rates and might not have, you know, equal means of treatment and things along those lines, which, you know, I think we discussed pretty well in William's several slides. So let's talk a little bit about prevention efforts before we wrap this up. I'm sure you've all heard me, if you've listened to any presentation I've given, talk about the community guide, which is a super fantastic resource of prevention materials and things that you can do to help reduce excessive drinking. Electronic screening and brief intervention, which I just mentioned in the previous slide. In terms of racial disparities, you know, folks in those groups might not be getting, you know, these benefits that are out there that, you know, some docs are using and some are not. We would be against privatization of retail alcohol outlets, alcohol sales, and what I mean by that is, you know, in Michigan, we are a control state, so essentially the state controls the alcohol and the sales of alcohol. So we do have obviously gas stations and everything that can sell, but ultimately it's not privatized in our state. Responsible beverage service training, so that's training our servers and bartenders and things. Dram shop liability refers to folks have, you know, various liquor stores and things being liable if anything were to happen with somebody drinking. So if a bar sold to, you know, a minor or sold to, you know, an intoxicated person and there was an accident, that particular establishment would be liable. Over service law enforcement initiatives, like I was talking about with serving folks that are already intoxicated. Maintaining limits on hours and days of sale. This is a big one, especially right now. We have a bill out there. I'm sure quite a few of you on this this webinar are familiar with the hours of sale bill that is proposed to increase our hours of sale here in our state until 4 a.m. I haven't seen a lot of movement on that bill lately. We did pass the cocktails to go and the social drinking districts bill, and then it did kind of come back up for review, but I haven't seen it moving. But please keep an eye on that. We will obviously try to, you know, slow any movement down there as we can. I produced a policy brief on that particular policy to try to educate folks on, you know, what's going on with that and what changing the hours of sale can do essentially in terms of alcohol related harms and things like that. So that's on our website, and I believe it's on Mike's website as well. Increasing alcohol taxes is one thing we talk about a lot. You know, it's a tough one to do, but it is something that has been shown to be beneficial. As, you know, more drinks become more expensive, people are less likely to drink them. So especially youth and folks that might not be, you know, as well off spending their money on alcohol that's more expensive. I've got a couple of hands raised, I think, here. Jessica, I'll unmute you first. Go ahead.
Oh, I'm so sorry. I was still, well, while I have you here, just because I was curious about the tax. So when alcohol sales are taxed, what happens to that tax money? Does it go back into maybe like substance abuse programs, or you're not sure?
So quite a bit of it goes into the general fund, and which obviously some of that probably does go into prevention. I think that there is a very small chunk of money from alcohol taxes that does go into prevention. I wouldn't know where exactly it goes, and Mike might be able to chime in on that he might know a little bit more about some of the where that money might go. I don't know if Mike, you want to chime in now or later.
You're right, Patrick. The vast majority that goes to the general fund. There may be a little bit, but the vast majority goes to the general fund.
Yes. So not a lot goes into prevention, unfortunately. There was a bill at one point, this was maybe the session before this, that wanted to raise taxes or I can't even remember exactly, but there was going to be some additional revenue and they wanted to put it in prevention efforts. And that was not that long ago. I don't know if it's one that's happening now with all the bills that have recently passed. I feel like it was last session though. So I think it's last session. Outlet density is a big one. And especially when we talk about health disparities, like Jessica mentioned in her comment, you, at least in many parts in our state, will find an increase in outlet density in, you know, neighborhoods that might not be as affluent as others. I was working on a project with Mike and Ashley looking at outlet density in Kalamazoo, and I bet you Rick mentioned this in his presentation this morning. Working in Flint, you know, we have found that in Kalamazoo, there are decent pockets of outlets in neighborhoods that are not as well off as some of the other neighborhoods in Kalamazoo. So, you know, that sort of health disparity issue with outlet density. We've got, you know, outlets in specific neighborhoods targeting specific groups. So that can be a big problem. You know, regulating outlet density is something that, you know, we work on often. There's a lot of literature out there on it. It is helpful. It does work when you're able to do it. Obviously in Michigan, it's not the easiest thing to do. We've got thousands and thousands of liquor licenses out there, and, you know, more and more probably coming. So, you know, it's a tough one, but it's something that we do know is helpful. And then obviously enhanced enforcement of laws prohibiting sales to minors. You know, anytime we can increase the enforcement of that, I think we can see a decrease in drinking. I do know that a law passed not that long ago that sort of lessened the punishment for folks, for youth getting their first offense. I think it turned in from like maybe a misdemeanor to just a minor infraction. So folks are kind of getting let off a little bit on their first offense. I think legislature thought, you know, they didn't want our youth to have a record so soon, that they were trying to give them sort of a freebie. And maybe some of y'all can speak to that as well, but that was something that did pass not that long ago. And I think that's all that we have for now. And obviously we'll open it up for additional questions. We have a few minutes for any other questions or comments or chatting of any kind that folks would like to chime in or anything. And I do see that Mike put some, and other folks put some stuff in the chat box, some various links and things that you could go to, it looks like, for some bills and things like that. Any
Thanks, Patrick. Thanks, William. Like Patrick said, we probably have a time for maybe one question, and then about 3:15, we're going to end the broadcast, and then you can come back on at 3:30 for the next session.
And obviously too, if you have questions we don't get to, please email us, me and William both. I know he would obviously be willing to follow up with anybody, email, call. You know, if you can't get a hold of me specifically, get in touch with Mike and he'll get in touch with me. We can figure it out. Yeah, please don't hesitate to reach out. So is there anybody who wants to add one last question or anything before we head out for 15 minutes to the next session? I don't see anybody raising their hand. Okay.
Any theories, just quickly, any theories on why, I mean, everybody's kind of wondering, but why the rates of female use is, you know, surpassed males in the last few cycles?
That's a great question. And I've been scratching my head trying to figure that out as well. And I honestly don't have the real answer. If I had the real answer, I probably have a paper published on it by now. But, you know, I think at this point we can only speculate, of course, but I think maybe part of it might be that male youth are moving on from, like, I think what Jessica said, moving on from alcohol to something like marijuana. And I think that our female population might not be as much. Kathy's raising her hand. I think she might want to chime in here. Kathy?
Yeah, I was just wondering, because alcohol can contribute to intimate partner violence, I didn't know if that would increase an incidence of female drinking, like in a certain period of time. You know, I don't know if you had a graph showing the intimate partner violence episodes, or, you know, if any of those were connected to alcohol use or not. Just a curious question. I'm not sure.
Yeah, no, I think there is quite a bit of research out there that does show intimate partner violence and alcohol are certainly correlated, and there is a large percentage of those you know, incidents that occur, and alcohol is certainly involved. I don't have that data at hand, you know, on hand specifically, but I know we can do you know, review and find some data out there that does show that. That is definitely a risk factor.
Just Ashley commented that in Kalamazoo, they're going to be doing some focus groups on this issue, so maybe they'll be able to shed some light once they do those. And Jordan reported maybe it's an equality thing, trying to keep up with the boys. I don't know if it's a marketing thing.
Or is it the thing where females can get alcohol more easily, especially our youth? Are they more easily able to get alcohol? I would think that they probably are.
Yeah, who knows? But well, thank you very much for the presentation. Like I said, we are going to conclude this session, take a 15-minute break, and we'll be back on at 3:30. We'll have Sarah Garchow and Shay Teller talking about a geofencing campaign, Expose the Truth geofencing campaign. So thanks again, William. Thanks again, Patrick. And we'll see most of you back here in a few minutes. Thanks.
Thanks, Mike.
Yep. Thank you, everyone. Oh, and also